Clinical Officers Association of Zambia. I sit on the regulatory body that we have in Zambia, which is called the Health Professional Council of Zambia, as one of the director in that board. And on top of that also, I serve as a vice chairperson of the Training and Examination Committee that is within the board, the Health Professional Council of Zambia. On top of that, again, within the council, we have got some exams that are called licensure exams. So these are exams that are based on competencies when individuals have finished their training, and I serve to be the chairperson of that training committee as well at that. On top of that, I think what is so unique about us COAS is that we are the largest group apparently that is sitting on the council, at the Health Professional Council of Zambia, with a membership of over 20,000. So that's a great, huge number, of course, in which we have been given a privilege as well for my member, who is the Secretary General, who happens also to sit in other committees that are within the council. So personally, personal experience, like I've got a bachelor's in clinical medicine, and I've got also the other part, I think, which is not really relevant, in which I've also done a bachelor's in medicine, which I think it was out of not knowing actually what we needed in life, because we didn't know really the progression criteria that was set for us. And I'm also apparently specializing in clinical pathology, that is on the master's level. My major law is on the training of the clinical officers, in which over the past 9 years, I've been involved at the primary core of training clinical officers, in which I've contributed to over 6,000 clinical officers that have been trained within our country, Zambia, which is the greatest achievement, I think, that I have as an individual, and will continue to support the training of the clinical officers in our country. I think that's what I can say for now. As we'll be looking on the very important topic, of course, taking into consideration to say, amongst these 20,000 clinical officers that we have, I think we have got a crisis in which a number of them, of course, haven't been swallowed or been taken up by the government, being the major sponsor when it comes to the employment. So meaning the topic of standardization might help us actually to transform our clinical officers so that they are able to work anywhere in this world, which would be the greatest achievement. If we are able to look at it with a critical eye, that will be heavy with this fruitful discussion this afternoon. Thank you.
No, sir. Forgive me. I will let the lady, because you have a special role today.
Thank you so much for this recognition. My name is Vivian Zame. I'm a clinical officer from Kenya. I also serve as the National Treasurer for the Kenya Clinical Officers Association. I've practiced clinical medicine for the last 13 years. I've specialized in medical oncology with 2 years experience. I also do lecture at the TVET College. I'm a recognized TVET trainer. So I do a program called Home-Based Care in the TVET colleges. Thank you.
Thank you.
Right, no, thank you so much. My name is Solomon David Ichomba. I'm from Malawi. I'm a clinical officer. I hold a diploma in clinical medicine, general practitioner, then the BSc in clinical medicine, mental health, then advanced masters in legal medicine and forensic psychology. I work with, I'm a business person. I run private clinics. I also work with the government. I think now this is my 15th year working with the government. I'm the president, actually the founding president of the Physician Assistants Union of Malawi. This is, I only have one term to be out of the leadership of PAUM. Thank you so much.
Thank you. Now, let's go back. Yes. He is the head. He will do other introductions. The president of all the educators in the world. And that's why I reserved him. Because we are going to talk about training and certification. So we have educators here from every country. He is their president. He's professor of professors and a lecturer of lecturers. That's what it means. And most of the discussions, in fact, you are going to drive it. I am not going to pose many questions. You are bringing the questions, should be directed also to him as well. Please, sir, can you tell us more who you are?
Thank you, Dr. Anthony. Very nice, warm welcome. I appreciate that. And I'm so delighted to be here at the conference. And just a shout out to the organization for this beautiful publication. Hey, I mean, this is amazing to have in our hands, take home with us. We can really be proud of what GACOPA is doing today and throughout this next couple days. And I'm just so delighted too, because I'm meeting people for the first time in person and shaking their hand and getting a hug. I mean, Dr. Anthony, we've been talking for several years online, first time to meet in person. You know, it's really great. Some of you I've met at other conferences. I look forward to meeting you at further conferences. Yes, I'm currently the president of IAPA, IAPAE, International Academy of Physician Associate Educators. I've been very fortunate to be the president for 4 years. It's typically a one-year term. We elect a president-elect, and then that president-elect moves into president, and that president then moves into immediate past president. And each is a year term, so it'd be 3 years of service. My term was extended during COVID as a special request to keep the transition going. And my term as president will end. I was actually past president, as I was introduced this morning, but our current president started a residency program in the United States and became very busy with the medical training. So the board asked if I would switch with him. So my past president became president again. And I'm going to transfer to Ms. Lambani Sosetsi. She is our president-elect. She will become president at our Lynchburg, Virginia conference in October, and I will be past president. So IAPAE has been in existence since 2007, and it has a set of bylaws which helps to guide it. And I think that's been very helpful for us as IAPAE, is we follow our guidelines, we follow our bylaws, we have elections with our annual general meeting, and then we have this succession plan for leadership, as I've just shared with you. And what we're trying to develop is regional directors in the 5 different global regions, and those regional directors can then reach out to the associations, the unions, the educators in that area to help build our membership, help build our activities. We have 4 main core activities. I shared some of you this morning what that is, but our main one is accreditation we're working on, and that's perfect for this topic today. And we do that project through Loop. That's the Learning Opportunities, Outcomes, Objectives platform, on online software for curriculum mapping. And we're mapping each of the country programs that have clinical practitioners around the world. And we want to gather empirical data that will show what is being taught, what is being learned, what is being assessed, and at what level in each country. And then we can finally have a comparison. And we can say, this is the standard that's happening around the world. And it happens to be a bachelor's, let's say. That's what we find. And that we would then promote that all institutions support this accreditation standard for us to meet. And it would probably be volunteer at first, but then I think everyone would catch on and want to be part of that IEPA accreditation and say, okay, we're going to have a bachelor's program as our minimum training. And then what should that content look like? So that we are all saying a bachelor graduating Kenya could then work in Zambia because they also have a bachelor's, could work in then Malaysia because they also have a bachelor's, could work in whatever other country we're talking about, because they would be the same. Now, just to share a little bit more of my background, I've been a lecturer at the University of Witwatersrand in Johannesburg for 15 years, and I've been the head of the Division of Clinical Associates for the past 6 years. I just recently stepped down and helped to organize the curriculum in that country. I'll talk more tomorrow about South Africa. We started in 2008, so we're still very young, 15 years. And I'm here with my colleague, Tabang, who's the head of the union. I'm also part of the PA working group for the International Labor Organization, as we shared earlier, to help with the new title of clinical practitioner and what that might be. I'm also on the working group of the Commission on Graduate of Foreign Nursing and Allied Health Schools. They are a United States nonprofit organization that assists foreign trained health workers to have visas and work permits to come into the United States, and through a process of verifying their credentials and looking at work opportunities. And so this group has just been tasked with PAs like myself to write standards for internationally trained clinicians to register as PAs in the US. So we're looking at that. Right now, the United States rule is that one must graduate from a United States Master Physician Associate program. And that's typically a 2-year master degree. I did my training at a university in Boston. So one has to have a bachelor's degree before that and meet the minimum entry requirements for a master program, which is often your basic sciences plus several other science courses, and having patient contact time, often 2,000 hours of patient contact time. Then you enter a master program. Upon graduation, you can sit for the PA National Certifying Exam. Following that, you're then able to present to a state PA licensing board to be licensed in that state to practice medicine. So this international nonprofit in the United States is welcoming any student who might be foreign but has taken a U.S. master degree course. Maybe they have a student visa, and they had a master student visa training course, so they graduated and they sat for the PA exam, and now as a foreigner, they want to come live and work in the United States, and we would help them for the visa. That's the rule right now, and of course each country sets their rules for foreign trained workers, whether they be doctors, be nurses, et cetera, to enter the country. Now, I've also been fortunate to work in Kenya, and I'm registered as a clinical officer through the Clinical Officers Council. They reviewed my degrees, my qualifications. I have a bachelor's degree in science, and I have my master's degree in physician assistant studies. I've since have a postgraduate diploma in health science education. And they reviewed those, and they said they meet similar qualifications, verified to their program in Kenya. And then I sat for an oral exam, and I sat for a written exam. Whew, it was tough. But they were very pleased with my answers and responses, and they then said I could become registered, and I started practicing medicine in Kenya, 2007, 2008, as a clinical officer. I then relocated to Johannesburg, South Africa in 2010, and again, I was able to register with the Health Professions Council of South Africa. They reviewed my qualifications, and at that time, there was no exam needed, just a review of qualifications. It went through the South African Qualifications Authority, it went through the Health Professions Council of South Africa, and they approved that. Currently now, we have that same process, but that approved person would sit for the South African National Exam. We call it the CANE, Clinical Associate National Exam, and that's administered by the National Clinical Associate Academic Team of the 3 universities in South Africa that teach and graduate the students. So we administer the exam, and we would have that foreign trained student sit for that exam. I support that type of process. I support submitting of qualifications, I support some verification, and I support a national exam. I think medicine is 50% common around the world. Anatomy and physiology is similar. A femur is a femur is a femur. 50% of medicine is common around the world. And we as clinical practitioners are trained to do common clinical conditions. We're the front line. You know, what is very common we see. I think about 30% of medicine is maybe regionally relevant, you know, to that region of East Africa, West Africa, South Africa. And then I think maybe 20% of medicine, 10 to 20%, is very local and very specific, and of course specific to the healthcare system that you're operating in. So as a person in the United States, I would know 50% of medicine in Africa. And then I would need to study up and be sure I knew the next 30% for East Africa and the next 10 to 20% for Nairobi and Nairobi's healthcare system and me operating in it. And therefore, I think it would be fair if I was tested at examination to be sure that I knew that other part of medicine that was required in that country, say of Kenya. Yeah. Now, I think I'm just going to stop there and maybe have that as some, you know, information for us to build on.
Yes, thank you very much, Mr. Scott Smalley. Yes, Scott. I have a question to Mr. Wachila, right? Did I get your name right? Okay. I have been trained as a PA in Ghana. Okay. Please, where are you from? She's been trained as a clinical officer from Kenya. We have Zambians, we have Zimbabweans, we have others. Some of the programs were designed in accordance with national needs. Why don't we mind our business and practice in our countries? Why standardizing and certification? What do we need? We have nurses, we have doctors, they can cross countries, that's enough.
Yeah, thank you. And that's a very good question. We were fit for purpose at that specific time. But I think with the evolution of the world and the need for more healthcare workers, we are no longer fit for purpose. We are actually an independent profession in the health sector. And we say that we have actually been able to map only 87 countries across the globe. Probably we have them in every country. It's only that we have not been able to reach them. So we have produced more than we need in our countries, our respective countries. But then in those other countries, including the so-called developed countries, they actually have a shortage of the health workers. And so they have the need. But where the problem is now is how do you transition that clinical officer, that clinical associate, that physician assistant associate from their jurisdiction to another one. And for me, I think we have three main problems that we really need to overcome when you are talking about globalization of labor for clinical officers. Because for me to be able to work in a different country, there are things I require. Number one, my competency and skills must be comparable to my analogs in the specific country that I aspire to work in. Number two, in that country where I want to work in, they must have a law that allows for equation. So that when I go there, there can be a regulatory body that will look at my papers, and then they'll be able to equate what I have with what they have in their own country. But now, looking at the competencies, the curriculums, and the certification across the globe for our analogs, you realize that, number one, we are not equal in terms of competence and skills, and in terms of also the number of years that we actually take to qualify for the different kind of certification, be it diploma, be it degree, be it masters. A good number of us, the basic qualification, you are a general practitioner. But the others, and especially those who are doing it at a master's level, and even some at the degree level, they specialize at basic. You are a clinical officer, a physician associate, a physician assistant, or analog at the basic, but you are actually specialized. You are a surgical officer or something. And these are the things that actually impede this movement, because sometimes it becomes hard for us to be able to equate. And so, and I like what IAPA is doing through the Loop platform, because I think we are trying to establish, because we must start with the status. What is the status currently? And I think that is what I've been able to elaborate, that there is no uniformity at the basics. And we must ensure that our basic, we have comparable skills and competencies, which is going now to facilitate that equation when we go into the other side. The other thing is that the certification level, there are some things that must also be looked into. The duration we take to qualify at the specific certification level, as well as do we then agree that probably the basic certification is going to be a diploma? Do we agree that it's going to be a degree? Because that is also important. When you are moving from one country to another, if I have a diploma and wherever I'm going, their lowest is a master's level, then it becomes very difficult for me. So the question you asked, it is very important that we are able to move because it's a global village. Number two, we have trained excess wherever we are, and on the other side of the fence, there is actually a dire need for the same skill. So we must be able to overcome the hurdles so that, number one, our people who are unemployed can be able to get that work elsewhere, and number two, so that the citizenry of the world, because as much as we are confined by our boundaries, I think the current emergencies, health emergencies, Mpox and COVID and the others, have made us realize that we are actually a global village and we must always care about what happens to our neighbor, because the next day it's coming to our home. Yes, thank you.
Thank you very much. Shall we clap for him? It's not enough. I'm impressed, global village. But what IAPA is doing to, I don't understand. We have a politician here, a lawmaker. They designed laws so that clinical officers can solve national issues, health issues. And that's why Kenya, Ghana, Zambia, they designed you. Okay. Don't you think this encouragement or this certification, what we have started, is actually going to facilitate attrition and migration? Is the focus not on better life outside our countries than health for all or proper health for all? Is that not what we are looking for? I'm asking Mr. Niba, don't you want to go to the US because you want a better life? And that's why you want us to standardize the training so you can practice there. Most of you migrate like nurses are going, and who will take care of the rest in the villages, the remote and underserved communities? The politicians are here. They created you for. You want us to regularize it? Oh, global village. You go out for whatever greener pastures and you don't come back. So tell me, do you have good intentions for this project?
I think that is a very interesting and tricky question to answer at all. I would state to say, when we train, we don't usually train for the local consumption. I would take, for an instance, in Zambia, we have really opened up in terms of our training, whether public or private institutions have come in again, and which happens to be the challenge. When you try to look at the skills, knowledge, and attitude, when you try to compare the two, it's becoming now a challenge on how to standardize the two. Our intentions, we are there to supplement the government efforts. That is the number one that we are looking at. If we've got numbers that are beyond to what the government needs, I think it becomes a platform also that we should be able to export our clinicians, those that have been trained. So our echo, of course, is to make sure we sustain our local needs. Once our local needs are sustained, it is also within this good spirit that others should be able to go abroad to go and learn what is being done outside. And as much as we know to say, when people are abroad, we are going to bring also new innovation that might also improve our health sector within our country. So including the revenue and the numerations that they are going to be getting outside, we will be able to boost our own as well. With that spirit, of course, to say, the only way to go right now is to standardize the training. Once we standardize the training, we are looking at it in this aspect. One, the skills are going to be equal. the knowledge is going to be equal as well, and the attitude that we expect. For we know to say the attitude is the only thing that usually amplify our altitude in life. So that will take care of us as well to say, as we are getting these competencies, we should be able to find some new avenues, not only in our country, but abroad as well. As much as we are lobbying for this also, we need to be kept in mind, medicine is universal everywhere. And when it comes to these trainings, when you look at anatomy, like Scott had put it earlier, anatomy, physiology, pathology, these are the same things. Non-communicable diseases are the same everywhere. When you talk about hypertension, you talk about diabetes, how we manage them, it's usually the same. So meaning, even if you were to go out, as long as you are offering a service that is there to protect the human being, you are offering the service that you are trained to as a clinical officer. So with that few remarks, I think really in support that this standardization should not be looked upon to say it is all about globalization, that people should be transitioning to go for greener pastures. We are looking at that again as a way of acquiring new information on how we can better our health system locally as well, through those people who are going outside. We are looking at a way as well to say how we can better our health system based on the revenues, also that others who might go abroad, they might be sponsoring the government that could have left. Because you might know, as we know, 40% in other countries when you're outside your country, whatever you make, you still contribute to the government well-being. So with that said, of course, you are indirectly boosting the revenue of your government despite you being abroad. So let us look at it also with the aspect of the monitoring as well as evaluating what we intend to do. That is on the one, if we can have a common nomenclature. Our friends have really worked well. Talk about the nurses. A nurse, whether you've got a certificate, a diploma, a bachelor's, you still be a nurse. Within ourselves, we have continued groomed with the idea of inferiority complex. It might be within the country. Once you attain a qualification that is higher than the rest, it becomes an entry point of changing your name. One, we take advantage of ourselves to try to favor us in terms of our remunerations. But indirect, that has killed us. As we continue learning again on the standardization, may we develop a motto to say, once you're a clinical officer, may you be a clinical officer regardless of your position, regardless of your qualification that you could have attained. With that, I submit. Thank you.
Thank you very much, Mr. David Chomba. You are my good friend. Uganda started their training in the 1800s. Am I right? Okay. Malawi. 1897.
Yes.
Why are we discussing this topic now? What made us fail? How did we fail like that? Or you don't call it a failure? So can you give us the historical background? Anything? Share with us. This topic should have been exhausted long time ago. Nurses have done this.
All right, no, thank you so much. Indeed, Malawi started this initial training with medical assistance. That's in late 1800 years ago. I think by then it was under the colonial rule. But if you look at the historical perspective of our health care training in Malawi, it's somehow miserable. I think you understand better why I say miserable. But things are kicking in the right direction now. So basically what the government of that time wanted is cheap labor. So they had to train people, equip them with all necessary skills to manage a facility, to manage a patient, but with a lower qualification and then a lower pay. And this were taken as a norm. So initially it was the medical assistants, I think from 1890 something up to around 1976. That's when the government thought of introducing a new cadre called the clinical officer cadre. So this clinical officer cadre was trained at diploma level. It was just a generic practitioner. And by then, I think being a clinical officer then, you were a big man in Malawi, completely a big man. You know, even when you're at college, you could say, when you come out from here, vehicles would wait for you to pick you direct for employment, houses and everything was there. So you were a big man. So the trend was like that up to early 2000. You know, when the medical school was opened in the country, that is around the mid-90s, College of Medicine. So they started training up the medical officers. Of course, by then, they would just get in some foundation, but they could finish up in Britain. So after that, they would come and work. But still, the numbers were very insignificant, to the extent that in the country, in Malawi, all health facilities, or even at our headquarters, Ministry of Health headquarters, all positions were held by our cadres, right? All positions. Till when the medical officer cadre started coming in, that's where now there was an issue of trying to remove somebody and take over the place, right? By then, when this thing was happening, there was nobody to represent the clinical officer cadre in the country. So because of that, it was so easy to remove some other people. Coming to around, I think, early 2000, some colleges began to advance this clinical officer from diploma, like St. John of God, where my friend Blessings Chikasema teaches, you know. So I started training people in mental health, right? So people could get in BSc in mental health, which I also got the same, right? It's a very good program, very rich program. I think most people from Zambia, they train at the same college. Yeah, so then after a College of Medicine came in with other training programs like, basically it was not College of Medicine, because College of Medicine, it's a college that is run by, I mean, it was training medical officers. So these programs came specifically to Malawi College of Health Sciences, which is the parent health training institution for our cadres. So there were some specialized programs like BSc in internal medicine, surgery, and all those things. But when College of Medicine looked at it, there was a good funding there, looking at the role clinical officers do. So the donors came with a lot of money for that. So you had to hijack it. So sciences was sleeping then, it was hijacked. You know, and then still the trend has been the same, but later they discovered when these people came out from college, because in Malawi, our cadres, they are main players. I think even there are a lot of studies. A clinical officer does everything in Malawi, all right? Can do anything, name what, we're able to do all those things. So what was happening is when they come on after their BSc, that was a threat. So it became, because of that threat, now the College of Medicine decided to try to scale down the numbers at the College of Medicine for these BSc programs. But sometimes it is good when something is happening to suppress you, be assured there's also something that is going to rise at the end of the tunnel, or maybe behind. So other colleges came in, like now College of Health Sciences. We as PAUM, we initiated, started visiting some colleges, said, no, can you have a career pathway for our cadres? So as I'm talking now, we have one of the best programs. I think basically it's one of the best, because I was part of that curriculum development. And from the scratch to the end, BSc, the first ever BSc in clinical medicine, offered by Malawi College of Health Sciences. And this program was benchmarked with the MBBS program. So if you look at the curriculum, it's almost MBBS. That's why it had some problems at the council. So the good part is I also sit at the council. So we had our own ways to make sure that the program passes. But it's a very good program. You can come and take and it's a very good program. So we did it for a reason. All right, so that they should be neck to neck, you know. So because we had a problem whereby
mental health, medicine, mental health, aphasia, several much.
Thank you. Shall we clap for him? I think there. Mr. Tahiru Fofana, you see, the subtopic is addressing the critical need for standardized training to ensure consistency and quality across the profession, which I think you will never achieve. You will never achieve consistency. You will never achieve quality. And you will never achieve it across the professions from one country to another. We heard Mr. Chomba. Even they are stratifying their own profession. Someone with certificate has a nomenclature. Someone with diploma has a nomenclature. That is a strata, right? It's like a caste system. So if snakes eat their own eggs, what won't they do to the flesh of a toad? And I'm saying, you're a global public health expert. So you understand globalization. Can you compare the quality of training to the United States, to UK? Is it achievable?
Thank you very much, Mr. Moderator. To start with, yes, it is achievable. If other cadres have done it, it is completely achievable. You see, when we are actually talking about globalization, like Mr. Scott was saying, in medical practices or in medicine, 50% of all this training cut across is the same. And if you are practicing, if you're going to practice from one region to another, definitely there is that 20% or 30% that you need to know specifically about that particular region, which is also achievable. The problem is, in the beginning, the clinical officer training, physician assistance training, or community health officer called in my country training was strategized for purpose. But we cannot continue to be like that, because initially these things were mainly run by the ministries of health and sanitation. And with the background that they actually knew what they were doing, that you wanted to produce somebody with high performance skill, but at the end of the day, you give that person a low qualification so you can pay the person less. To this, I think it is completely achievable if we can come together. For example, in West Africa, there is West African Health Organization, the WAO. They did make move in order to standardize curriculum, and this was set at a bachelor degrees level. Currently in my country, that is what we are using, and the program has been moved from the Ministry of Health. It is under the Ministry of Education. So they are offering you a bachelor's degree in community health and clinical science. This is with the backdrop that they are not producing you for local consumptions. We are producing people so that they can be internationally recognized, they can serve in other cadre, they have a smooth way of upward mobility. But the challenge comes that in most African countries, the Ministry of Health and Sanitation, via the government, do not want to spend on health. So they want those to retain people at that level, and they will be like thinking that if we produce them, they can go. It's a brain drain. These are far from it. We had a discussion around brain drain in relation to globalization, that if you allow this free movement of labor market, it will cause brain drain. To me, I refer to it as brain circulation, because if I come to Malawi and practice as clinical officers, I will learn something from Malawi, from the system of Malawi, which in turn, after like 5 or 10 years of practice, I can take back to Sierra Leone and establish it and improve on it. Likewise, people from Malawi can move. So it's going to be like a brain circulation. Excluding that, if we do still have enough manpower, like my brother, for example, came to Sierra Leone in 2015 when we had our Ebola outbreak. Had it not been that other African countries will come to our aid, it was going to be very difficult. Had we had a system where there is this uniformity, there is this standardization of clinical officers coming to Sierra Leone to practice, it would have been much more easier, because if Kenya is producing much more, Kenya can export. Take example for today, the world. India is one of the largest exporter of IT technicians in the world. Does that make them not having enough? No. It is about our individual system to see how those that we have, those that we've produced, how do we value them and retain them? We should produce people and to a standard that they can compete internationally. They should be able to compete internationally. It should not be a one size producing all the time. For example, you come to Ethiopia, it's a different thing, I can't practice. It becomes very, very difficult. So as we are in the global world, what we are pushing for is our discussion should be a patient center. And how do we provide high quality standard for patient? I can come from Sierra Leone and get sick in Botswana. Should I not receive a standard care? I should receive a standard care from a standard professional. Therefore, if we try to see how we universalize our training to ensure that at least we upgrade from that 50% to a 70% standard, that anybody can come from Ghana and practice in Sierra Leone. Just like a doctor can come from anywhere and go to Sierra Leone today, you only have to take your exams. Like Scott was saying, we are not against saying the accreditations to verify your document or to take exams. These are necessary things because we must ensure that we maintain standard. But as much as we want to maintain standard, we should push beyond the boundary and see how we can universalize our practices, how we can standardize the training and certification so that somebody else coming from Sierra Leone will have the opportunity to practice in the UK. Somebody coming from Kenya, we have opportunity to practice in Liberia. Thank you very much.
Thank you so much. Shall we clap for Miss Vivian, right? Very good. As we move to standardize our training, of course, trainings are done in the training schools. In Ghana, we have a challenge. The Medical and Dental Council came after the schools because we were becoming too noisy, according to them. Advocacy was very strong, so now they downgraded some of the schools to about 3. Okay, they used the law. Because of that, I led my people, then we decided to solicit education, outsource education. One of the countries was Ethiopia. Ethiopia has Master of Science in Integrated Emergency Medicine and Surgery. After 10 years, one of the schools, we discussed with the council, we signed an MOU, but they told me they stopped the training 10 years ago, after 10 years. Do we have some of the surgical officers here? We have them in training, but they are not training again in Ethiopia. How do we standardize our certification when there is a global call against a national need? The nation says that maternal mortality and child mortality was very high, so they needed the emergency surgical officers, use them, and after 10 years, they stopped the training. So those who are there are the old ones who were. So we wanted to reopen with a university, and we sent a proposal, and we will be starting, they said, their next year, because they had some few crises. And they are doing it for us in West Africa, not for the Ethiopians again. How can we blend this global vision against this national hurdle of people? In Australia too, I saw it, that they stopped training in some schools. And some of the people, as for Ghana, if I'm to lay down the history, it will be very long, because if they find out that you are doing well, we produce some clinical dermatology officers. They produce 15. The people who were lecturing were doctors, medical doctors, dermatologists. They said no. In Ghana, we have about 12 dermatologists. We already have 15, they are doing so well. So how do we blend our global vision with the national challenge of they ceasing our training. Thank you.
Thank you so much. I'll begin to say that where there is a need, there's going to be a change.
Hello?
So when we talk about our national policies and programs that affect the way we train our people against the global world or the global village, I believe globalization needs structures, and also for the national policies to go ahead with each and everything that we need to do, it also needs structures. So we all begin with structures. If you know where you want to go, you will put a first step. So I'll give a practical example of Kenya, and maybe I will just analyze how the clinical medicine fraternity has been able to put up structures that have shaped up even the way our career has gone. Currently, we have the new career guideline that has given us a very good key pillar or a step on how we can be able to grow clinical medicine. So what happens in Kenya is that we have the council, which is the Clinical Officers Council, and we also have the Ministry of Health that is basically working on making the policies for the clinical medicine. Then the council controls the registration and the training of all the clinical officers. Then from the council we have the association, which takes care of the welfare and the well-being of the clinical officer, how they practice, how they should be able to handle the patients generally. Then we have the union that relates on issues about the labor issues. So from that, we can be able to see how we can be able to have a clear pathway on how we should at least carry ourselves as clinical officers. That is what we say about structures. So when we have good structures, just for the nation, and then we try to align ourselves with the World Health Organizations, it becomes easy for us to cascade any ideas that might come. So for instance, today we are here, we are talking about GACOPA. It's talking about the clinical officers and the PAs. And we are trying to bring ourselves into one. And when we talk about oneness, it's about unity. We can be able to have one voice and talk about our issues as clinical officers. So I think for me, we are on the right trajectory, despite the fact that we have different policies in our different nations. And definitely, we have administrative issues. For instance, what we can be able to practice in Kenya might not be allowed to be practiced in another country. For instance, in Ghana, as you had said, you guys were relying on Ethiopia to train you for the masters that you had talked about. So I think policies need structures, and when you have good structures, you can be able to identify a clear pathway. Thank you.
Shall we? She's the only lady, the only female. What a beautiful... Mr. Scott, the IAPA president, I really don't like what United States is doing. When we first met in Rwanda, we spoke about some few things, and I remember approaching someone. I will hold a name, and we were thinking we were going to universalize. He told me United States will not universalize. That's what he said. When you came to Kenya, did you have to train again? You did not, right? You didn't go to school again. When you came to South Africa, did you train again? You didn't have to. You presented your credentials and it matched. I want to go to the United States, and they have built hurdles. There is legal and professional hurdle. Even in Canada, you cannot train there as a PA if you are not a citizen or a resident. It's there. I think in the United States too, yes, it's in there, NCCPA. Maybe I stand to be corrected. And then, if I have to move there, it will be very difficult for me, but it's easy for them to come here. How can we resolve that?
Very nice question. Thank you, moderator. Yeah, so as I said in the beginning, each country is setting their own standards and their own accreditation and their own process for foreign-trained healthcare workers to come in. And the rules of the United States set by the NCCPA, National Commission of Certification of PAs, has said that all PAs who can sit for the national certifying exam, the PANCE, Physician's National Certification Exam, must have graduated from a master degree program and produce a master degree, and passing those qualifications of that university or college, then they can sit for the PANCE. And upon passing the PANCE, you then can be registered as a PA-C. I'm a PA-C, Physician Associate Certified. And then I can take that certification and my master level qualification, and I can go to the state where I reside and work, and I can register with the PA board for that. So that's currently the rule. Now, many master programs, there's 340 master programs in the United States, are starting to accept foreign students into the United States and into their master program. So then as a foreign student, you just need to have a visa that would allow you into the country for study, and you would need to meet those master program pre-requirements. Many of the programs require then a bachelor degree. That could be a 3 or 4 year bachelor degree. And then even with that, you might have to demonstrate certain courses that you'd have to take. So I had a bachelor degree in the United States, and I decided to go back to school for my master program a little bit later. I was an older student, and so I didn't have all the necessary courses. I actually had to go back to do some 2 years of prerequisite courses in order to qualify to apply to master programs. So even in the United States, some of us might have to do that. So as a foreign student, might have to take some prerequisite courses. Then you'd be accepted as a foreign student with that study visa into the master program. And then you could sit for the PANCE because you graduated from master program. And then you could get support for a work visa and stay in the United States for employment. Now, I don't know about Canada, so it'd be interesting to find out more, and I think this is something that IEPA wants to do. I've often asked questions, where can I go to work? Where can I go given my studies? And I'd like to start studying and researching each country's requirements, and within those countries, each university's requirements to sit as a student. I think we could start posting that on our website and really provide good information for all of us, because we really are moving into a global village. We are, a global society. We have information zooming across the world. Just today on Instagram and on Facebook and on WhatsApp, I've been messaging colleagues all around the world. I mean, we transport, our friend Dr. Mike is going to go to Dubai after this. I'm heading back to South Africa. Everyone's going to their country, but you're going to the next country after that. We are so global, and I don't think we should limit that type of movement. We do have to be very careful, though, what that movement means for the loss in that country. There's been the International Nursing Commission has just put out a request for WHO to stop the migration of nurses to other countries and stop promoting that. I've read Sierra Leone has lost 20% of their nurses in the last 2 years because of a movement to other places. And other countries have lost 10% of their nurses because of a move to other countries. And that's really devastating for that country to lose 20% of its nurses, already short of nurses. And what right do these, more wealthier, resource-based countries have for, taking those away from a country that needs them? So I think there needs to be a real balance in how that happens. If people move from country to country, what's being taken and what could be provided? I have this far-reaching idea that if a country has 20 colleagues coming, they must replace the 20 colleagues with other workers that are needed there. I like this brain circulation. So let us have healthcare workers, but let's circulate engineers. Or let us have lawyers come and let's circulate healthcare providers. What does your country need? What do we have? So how can we kind of have more of that reciprocity and more understanding and more giving and less taking in this future? We're moving into this future. We're moving to this future, and there are countries such as the United Kingdom through the General Medical Council that's already started to put together minimum qualifications of foreign-trained health workers, specifically PAs, to come to the NHS. They realize they do need them, and they're starting to look, and that will be happening. So I think this movement is upon us, and I think we need to be part of this, and I think IAPAE with GACOPA can lead in recommending accreditation standards for a bachelor's degree. I think the recommendation we'll find is that a minimum qualification is a bachelor's degree, and that therefore anywhere around the world we have bachelor's training so that we can immediately start comparing to other countries. And then I think within that we should have a very straightforward system of verification of that qualification in other countries. And I think we should support countries to establish a national exam which foreign-trained employees, workers could come and take. And I think that'd be very appropriate. I mean, I didn't learn anything about malaria in my studies as a master-level student. When I came to Kenya, I had to quickly, learn and how to treat that. Also, I wasn't as versed in some of the trauma situations that happen in South Africa. South Africa has a high level of trauma that occurs, and that really needed to up my game there. There were areas about the healthcare system I didn't understand in South Africa, different from the United States, that I had to learn. So there were areas I didn't have to go back to school, but I did have to up my game and learn, to be able to meet that qualification. I think that's very understandable. I think IEPAE and GACOPA need to put forward these standards for what is a bachelor degree as a minimum qualification. And then I think we need to put forward standards for what a master's degree looks like and what a PhD is developing and what that looks like. And I think then we can set a standard that we can work towards. I mean, already in the United States, there's discussion around should the PhD be a minimum training for a physician associate. So 2 years ago, the NCCPA and the PA-ARC, that's the Physician Associate Accreditation Review Commission, decided that a master's degree is the minimum training. So you needed a master's degree to sit for the national exam. It used to be a bachelor's degree. Now it is across the country a master's degree. And there's discussion that it should actually move to a doctorate degree. So that's even like a step higher. That even gets further out of reach for the rest of the world to think about. And I'm not sure I support that as a USPA, that we should be at a doctor level. Why? I don't need to be a doctor level to practice good medicine as a PA in the United States. I'm currently doing that as a master's. And I have to say, one last thing I have to say is I am so impressed in the other countries where I've gone to work and to visit, and the work that clinical officers, PAs do in other countries. Because I think your training is fantastic. Your diploma training and your bachelor training is in many ways better than my own master training. And it's longer years, and it's more in depth, and it's more with at least areas of medicine you're exposed to here. And it's in much challenging situations. I mean, resource-limited hospitals, resource-limited clinics, staffing isn't always available, patients are presenting very late, distance in transport is difficult. I mean, it is really incredible medicine that's being practiced here, and I have much to learn, and other PAs as well from the U.S. have much to learn from you guys. Thank you, Dr. Tony.
Thank you. Shall we clap for him? We have less time. We're about to take questions from the audience. I asked that question because if there are restrictions, whether legal restrictions or professional restrictions to work in other countries, we set them. And most of the time, it's either the certification, the PA body certifying the PAs to come will tell you, hey, don't come here. Or it could be a national law or a federal law that is actually prohibiting. Like I said, Ghana, other countries, and many other qualifications like nurses, doctors, pharmacists. And of course, even with, all they need is that you are board certified. And most of the time, the NCLEX that the nurses write, they don't write another bachelor's or have to study in the US or UK. They take them through rotation. Even MBBS, I don't know how the US MLE, they don't have to go to another medical school for 6 years again, or 4 years, or whatever it is in the other countries. So this is what I'm saying, that we have set the laws, we have set the rules, that our own people should not come here. They should not have the qualification, or even if they have the qualification or the kind of training, it is not up to that standard. But most of the time, I have seen, once we are done with what we are doing, what will be left will be professional ethics and medical legal considerations, which I know is very high in your area. Because here, if a patient became aggressive, maybe a psychiatric nurse or a mental health practitioner so aggressive, there's a way to restrain. But outside there, my friend will say you have to seek consent a lot, maybe about 3 times, even rating with a psychotic patient before you can even administer a drug. So those are just the few restrictions. But to go through education again, you sit on a very high throne. Okay, that I think these things can be done. I will take advice when it comes to legal barriers to our practice in another country from our honorable member here. Please, can you share with us there are laws in each country and nation, but it has been easier. You are a doctor, and it's easier for a doctor to move from one state to another, but there are few processes to satisfy, and a doctor doesn't probably have to go through a re-education or again go to medical school again. In most cases, an MBBS has been universalized, and it has been very possible because some of these laws have been removed. Nurses do the same thing. You just have to be board certified. They look at your qualification, WES or some of these world bodies, they certify your credentials, and then you are good to go. They pass you through training and co. Can you share with us what we can do so that we will be able to remove these legal barriers that doesn't permit us to enter into another country? Then we take questions from the audience.
Thank you, moderator. I think the most important part is getting accreditation within the various bodies. Your training syllabus needs to be accredited. You will find that even within your own countries, your council has to accredit certain facilities to train. Now, within the Commonwealth countries, you will find that the training is almost similar, whether you are in Britain, you are in Canada, and all those other countries. And therefore, and also because of commonality in the language in which you speak, English being one of the universal languages within those countries, then you'll find that that will also promote issues of recognition. Within the East African country, as I told you initially, the first university to start training doctors was Makerere. And Kenyans went to Makerere, those who wanted to train as doctors. They went to Makerere, trained as doctors, even pursued their masters either in Makerere or in the UK. Then after that, they came back to Makerere. And in 1965, when Kenya wanted now to start the training of doctors, Professor Mungai had to be poached from Makerere University because he was teaching there. And Professor Mungai brought the first two cadavers. He brought them from Makerere through Busia border. And when he arrived at Busia, I think he was even arrested by police because they found him carrying dead bodies. And the president had to pass, the late Mzee Jomo Kenyatta, who was the founding president of Kenya, had to personally intervene. Meaning at the higher level, there must be intervention, there must be political will for that. And that's how medicine was brought into Kenya. And subsequently, as you train doctors, because these doctors initially trained from Makerere and even went to the UK. So you'll find that there is that recognition within the Commonwealth, that if you are a doctor from within the Commonwealth, then you don't have to sit for board exams. You can only maybe, if you want to go for your master's, and then you, as usual, like in Kenya, if I want to do, after doing my first degree, if I want to do master's, I have to sit the examinations for that institution. And then once you pass, then you are now admitted and you're able to practice. So similar to that. And I think that is the same issue with the clinical officers, that first get recognition within the region. You have to have a regional body that will be able to recognize you. Then you can now move from that to globally. And then at that level, then with that accreditation, you can be able now to work anywhere where you think your services can make a difference to health. Thank you.
Thank you. We've come to the end of our discussion. I'll take questions from the audience. There's some few. Okay, I saw him. And we will come to a close. You can address the audience.
Yeah, thank you so much for the good points that have been said. Probably the first question as well, thank you so much. You posed a very good question in the first place, saying, why should we standardize now? It has been there. Why now? Why are we standardizing now? Probably we should as well bear in mind that we as countries, we have got borders. Borders, right? I would give you an example in Malawi, whereby we have Mwanza district, and which borders with Mozambique, as well as Mulanje district, which borders with Mozambique as well. There are high rates of NNDs, MDs, high rates. And once you go there, you will see that the rates, more of the cases have been referred from the neighboring countries because their hospital is far, right? So probably I just wanted to add that. Now, looking at the theme, it's universalizing of the practice or globalization. We should standardize. I think this meeting, we are focusing, we want to standardize globally at once. As academicians, as professionals, is it practical that we can standardize this globally? To me, I felt probably GACOPA, you are doing a great job. We are doing a great job, not you are doing, we are doing a great job as GACOPA. We have clinical officers from Kenya that have trained in Malawi, even clinical officers from Malawi that have trained in Kenya, especially Mount Kenya, Bachelor of Science, Clinical Medicine and Community Health. They are registered in Malawi. Some are registered in Zambia. Why can't we probably start as a pilot to say we select countries, let's say Malawi, Zambia, Tanzania, Kenya, South Africa. Why should we start as a pilot and see how helpful it is, so that when we are presenting to the policymakers, we tell them to see, look what is happening, instead of coming out big. Probably we are dreaming big.
Okay. Thank you so much for, that's a contribution, right? Can we clap for him? The panel will answer. Yeah, please, brief one. You don't have time. I will hold the mic for you.
No, thank you. I'll be very quick. I was listening to my brother from Sierra Leone when he was talking about going back to the community. And mine is not a question, but just to agree with him and various speakers who have spoken before. And I'll give an example of our focus. Part of the question we should ask ourselves, standardizing, we are doing this for the sake of the patient that we are taking care of. We are not doing this for the sake of the professional. Of course, now I was thinking about the outbreaks that have been there, the COVID, Ebola. These diseases, they do not choose whom to attack. They attack each one of us in our various countries that we live in or where we're coming from. Another example I'll give is Kenya is bordering Uganda, and you'll find most of the eye-related issues, they are going to, there's a hospital in Tororo. I said it is not a question, I said it is a contribution. So I was just emphasizing on what they were saying. And lastly, there's one who was talking about the policies in the US and other countries